Good afternoon, and thank you for being here today. My name is Leslie Dow-Twitchell, and I want to talk to you today about reinstating the licensed practical nurse into the acute care setting. My agenda for you today is to talk about why I'm making this request, what the need is, what I perceive the need to be at Vermont's largest hospital, a brief project description, a budget to initially roll out this project. I'll sum my ideas up for you and then take questions from you in the audience. What's our need? There's a lot of conversation today among RNs and LPNs about the nursing shortage at the hospital and at various medical facilities around the city of Burlington. And there's some ramifications that we're feeling with regard to the nursing shortage. And specifically this shortage is with regard to RN, registered nurse patient ratio, at our hospitals. And the ramifications of not addressing this shortage show up in very palpable ways. The three that I'm going to look at today are failure to rescue, poor patient outcomes, and medication errors. Failure to rescue is the death of a patient after a complication of a treatable medical condition. And hospitals with high patient-to-nurse ratio statistically show in risk-adjusted studies that they have higher mortality and failure to rescue rates when we have more patients to less nurses. That is ramification number one. We see more failure to rescue. Ramification number two of our nursing shortage is patient outcome in general. And staffing variables matter, and there is a strong and consistent relationship between nurse staffing and variables that staff administration look at, like nosocomial infections such as UTIs and hospital-acquired pneumonia, and patient length of stay. The better the ratio of nurse to patient, the less we see a long length of stay for a patient, and the less we see hospital-acquired infections. As well, patient outcomes and RN share of total staffing get better as we divvy up the nursing duties to various licensees, such as LNAs and LPNs. So again, in risk-adjusted studies, we see that when we are spreading out our nursing duties among staff, patient outcome is better. And then ramification number three is medication error. And this is a big one, it's in the news a lot. Heavy patient-to-nurse workloads increases medication error. And why is this? This is because in hospitals and skilled nursing facilities, nurses deliver the majority of the medication. And while medication errors may happen at the prescription and dispensation phase of medication delivery, most errors happen when there is a heavy nurse-to-patient workload and nurses do not have the time to critically think all the way through their medication delivery. And again, med administration errors account for 26 to 32% of total med errors in the United States. And again, nurses administer most medications. And there is a very strong correlation between nurse-to-patient ratio with med error. That is ramification number three of our nurse staffing issue. So how does it work? What's our solution to this? And I think that we need to look at a lot of different solutions, but I think one that could really be set into motion pretty quickly is in order to adequately staff our hospitals, is to reinstate the LPN into the acute care setting and make the LPN, fold the LPN back into the workforce on the acute care setting. And what this means by adding LPNs back onto the floor, we would need to then roll out an education forum for the preceptors that will be training the LPNs, and to budget into floor staffing the cost of having an LPN on the floor, which incidentally will be a little bit less than increasing the number of RNs on the floor. And what this also means is that it expands the nurse hiring pool. So by including the LPN back into the hiring fold, we are then we're making a bigger pot to pick from, which also means that we are getting more qualified people into our hospitals to care for our patients. So what's the impact on our hospital? We talked about the ramifications, 3 of the ramifications that nurse staffing ratio affects. We talked about medication errors, we talked about patient outcomes, which are huge for insurance purposes for sure, and we also talked about the failure to rescue. All of these issues have a direct effect on our patient's ability to successfully rehabilitate. They also have a direct effect on patient and family satisfaction. And this is key because patient and family satisfaction directly affects our bottom line. It directly affects the amount of reimbursable that insurances, Medicare and Medicaid, will give to the hospital. So the higher the patient satisfaction, the more money the hospital gets. The lower the patient satisfaction, the less money the hospital gets. So what would it look like? What would it look like money-wise to roll this project out onto one floor in the hospital just to try it, to look at it and evaluate it after rolling it out? And I allocated $125,000 to roll this out onto one floor in the hospital. And what that would mean was $15,000 in labor to develop a training module. Another $15,000 in labor to train preceptors, so to train the people that would be training the LPNs to fold into the workforce. I allocated $20,000 to the unit manager of the floor that would be working on this rollout, and $15,000 for the nurse educator to oversee the project in general. $25,000 for the preceptors that will then actively be working, once they're trained, actively be working with the LPNs on the floor as they're orienting. And then another $30,000 for the LPNs themselves to get them hired and pay them for this rollout orientation period. And then I added $5,000 in the budget for materials and out of pocket. So again, I really believe that we could roll this out for $125,000 and evaluate the process effectiveness from doing it on one floor in the hospital. So currently, we're all well aware that it's very difficult for the registered nurse to efficiently practice to her fullest scope. Nurses perform a lot of tasks that keep them very busy and keep them from being able to work effectively at the bedside in critical situations. And I believe that the LPN can offload some of this busy work, allowing the RN to practice to her fullest scope, to think at her most critical level, to interact with doctors and providers at her best level when she's not tied up with busy work. These tasks consume her time and attention, and that literally takes her away from a higher level of critical thinking. So again, I believe by reinstating the LPN into the acute care setting, we are offloading work that's absolutely necessary to the recuperation of our patients and to the outcome of their stay at the hospital, but that could be offloaded again to an LPN, leaving the registered nurse the ability to function at her best and highest level. Are there any questions from the audience? Thank you so much for your time, and have a lovely afternoon.